Greetings to all OrthoTV viewers. Today we bring a unique program which has been in collaboration with the Myers College of Physiotherapy or the Myers Physiotherapy College in Talegaon. We had a series of talk by Dr. Kothari sir, who had kind of talked about the recent advances in spine surgery, which has been already streamed on Physiotherapy as a part of collaboration with Myers College as part 1 and part 2 of his talk. To take this further, today I invite Dr. Ravinder Kaur to kind of speak on the aspects of physiotherapy following spinal surgery. Just to give a brief introduction of Ravinder ma'am, Dr. Ravinder Kaur is working as a professor and the HOD of the Musculoskeletal Physiotherapy Department at the Myers College of Physiotherapy, and she's also presently a PhD scholar from the Gujarat University. She has completed her graduation in 2004 from the Indore Institute of Medical Sciences, and in 2007 she completed her master's from Sancheti Institute College of Physiotherapy. So we have a very proud alumni who is working as a professor in Myers College. She has a UG teaching experience of 17 years and a PG teaching experience of 10 years, and she's a certified UG and PG teacher in MUHS Nashik. She has completed even her postgraduate diploma in hospital and healthcare management from Symbiosis Institute, Pune. She's a certified Mulligan practitioner and has 10 research publications to her credit in various national and international journals. She also has a book published under the Lambert publications, and her special areas of interest are rheumatoid arthritis and spine. In fact, she has recently copyrighted the Indian Hand Function Assessment Scale for rheumatoid arthritis patients as also a part of her doctorate studies. I welcome you, ma'am.
Good morning, everyone. Today, we will review the most recent evidences regarding post-op treatment after cervical and lumbar spine surgery, and we'll go through the guidelines to make recommendations for rehab. Anterior cervical discectomy and fusion is currently the most common surgical procedure on the cervical spine, followed by cervical disc arthroplasty, posterior and anterior cervical foraminectomy. The effectiveness of cervical spine surgery on radicular pain is moderate to good, but effects on neck muscle function is still less clear. During immediate post-op rehab, there could be reduced neck motion due to fusion, pain, post-op immobilization. All these factors can lead to reduced neck muscle function. And the reason could be atrophy or deconditioning of the muscle, which could be a responsible, or we can say that could be a reason for the persistence of symptoms in many patients after surgery. Today we'll look for post-op rehab following anterior cervical discectomy and fusion. Following any spine surgery, post-op rehab is considered important and is largely recommended by surgeons to help patients improve their functional status and achieve their recovery goals. So these are few activity-based goals which are formulated by surgeons. Like in short term, they want their patient to get improved in their functional status, ADLs, personal care, and then with housekeeping tasks if it is recommended. And then in long term, they should be able to return back to their work, sports, or leisure activities. So based upon this, there are few guidelines for this rehab. Phase 1, Phase 2, and Phase 3. Phase 1, the initial goal of rehab in which we are going to concentrate over reduction in pain and inflammation and closure of wound. Phase 2, surgical site should be protected until there is a connective tissue formation and the bone will show some evidence of mineralization. Phase 3, in which we'll go for the gliding of the neural tissue surrounding the surgical site to prevent formation of adhesions. So based on that, the Phase 1 rehab is for 2 weeks, and all these phases are overlapping. In this phase, mainly we are going to educate patient regarding proper use of cervical support if it is prescribed by surgeons or PT, protection of surgical site. We have to teach correct body mechanics and maintenance of neutral cervical spine position. This is very important because then this is the basis on which our rehab will be formed further. And we have to introduce a small amount of aerobic conditioning to the patient in the form of walking program. Phase 2. In this, we can initiate with gentle stretches to pectoral group of muscles, gentle upper extremity range of motion in which the shoulder ROM should be below 90 degree, scapular retraction exercises, and main important over here is recruitment of deep neck flexors. As we know that there is a reduction in cervical neck muscle due to atrophy and deconditioning, which could further cause weakness of the muscles, and patient, there will be a what we can say the functional outcomes of the patient. It will reflect in the functional outcome of the patients. So we should start with deep neck flexors recruitment from this phase, trunk bracing techniques in multiple planes, so that we can start with the basic like supine, prone, sitting, and then it can be progressed to the weight bearing positions. And we can go for walking program from 15 to 20 minutes or as per tolerance by the patient. As we know that kinesophobia, there are researchers or the literature which talks about kinesophobia, that is a fear related pain. In this, cognitive behavioral therapy works wonders. So we can start from phase 2. Phase 3. In this, you can start with shoulder ROM exercises above 90 degree ROM, and you can begin with gentle assisted or active ROM as prescribed or as tolerated by the patient. And plus, we can also start with neural tissue mobilization. If the same extremity is painful, we can start with the contralateral or the other upper limb if the lower limb is involved, or if lower limb, then upper limb we can start with. So we can start with remote sliders from this phase, and we can begin the deep neck flexors with limb loading from phase 3. Ultimately, our aim is that patient should be able to maintain neutral spine position, neutral spine into different positions, so that which mainly these positions will be functional positions. So for that purpose, we have to start training from phase 3. You can start with resistive training, but it should be, the shoulder should be below 90 degree. Upper extremity strengthening can be started, and thoracic mobility and thoracic soft tissue mobility can be started now. And walking tolerance can be increased to 30 minutes. As we go for the further, the phase 3 is divided into 3B. In this, we are going to progress the resistance training, the closed chain exercises, deep neck flexors training with limb loading. We have to progress. We have to progress the aerobic conditioning of the patient. We can add up therabands with PNF patterns, so that these movements can mimic the functional movements. And after 24 weeks, we can progress or we can incorporate activity-specific training, sport-specific training. Patient can start with contact sports training now. You can progress the functional training so that patient can return back to their work or to their specific sports. There is insufficient research on specific structured exercise programs that are effective treatment after surgery of cervical spine. So there's one RCT for 6 months follow-up they have done, and they have included patients who went for cervical spine surgery for cervical disc with radiculopathy. They have shown that might be the benefit could be minor, but it has a benefit over, we can say, the structured post-op rehab. It has a benefit over the standard protocol. And basically in this structured is a tailor-made protocol, which includes mainly the combination of exercises, like I have told you, like kinesophobia, fear-related pain, that can be tackled up, neural tissue mobilization, deep neck flexors training, and cognitive behavioral therapy or pain coping strategies, we can say that. And most important is involvement of home exercise program to have a maintenance effect of your exercises on the patient. So these are the multimodal approach RCT, which shows that if rehab is started in a early phase of your healing period, then obviously it is going to increase functional outcomes of the patient. Now let us go for the second part, that is rehab following lumbar microscopic discectomy. There are a few primary goals that should be taken care of or while post lumbar microdiscectomy. Main are reduction of pain, prevention of recurrent herniation, maintenance of dural mobility so that there could be improvement in the function and patient can go for early return to their appropriate activities. When we are planning patient education program or ergonomic advisors, this is the graph which is talking about lumbar intervertebral disc pressure during different positions, body positions. So we should keep this thing into our mind while planning ergonomic advisors and education program and rehab of the patient. Literature says that the therapist must avoid all loaded lumbar flexion in patients in phase 1 and phase 2. We can see that loaded lumbar flexion in standing and sitting position has a tremendous increased intervertebral disc pressure. Standing motion testing or end of range movements are not assessed till 5th week post-op. Even slump testing should not be done until 5th week post-op. And main important is hip muscle strength. Hip muscle strength testing should be postponed in the early stages of the healing to prevent stress over inflamed lumbosacral tissues. So these are the basically contraindication for assessment that should be taken care of when you are going to assess your patients in the early stage of healing. So phase 1, that is a protective phase for 3 weeks. These goals are formulated based upon anticipated impairments and functional limitations, which could be in phase 1, could be pain limitation. Pain is limiting the nerve mobility, plus like limitation in trunk muscle strength, lower extremity strength, lower limb and thoracic mobility, limitations in nerve mobility, poor recruitment of core muscles or rather paraspinal muscles, limited cardiovascular endurance, and limited tolerance to ADLs and sustained postures. So these are the functional impairments that should be taken care of while formulating the goals for the phase 1. So the goals will be to protect the surgical site, to promote wound healing, maintain the nerve root mobility. You have to reduce pain and inflammation and minimize fear and apprehension of the patient, and establish good body mechanics for safe and independent self-care. So the intervention will be based upon these goals. So for decreased pain and inflammation, we can go for icing and TENS. Corset, if it is prescribed by the surgeon. Body mechanics training, so that patient should be able to understand what is neutral spine. And literature talks about it takes 4 weeks for the patient to come into the neutral spine and use that neutral spine into different positions of the body. Transfers, teaching dural mobility in non-dependent positions, mild stretches to the extremities, and to improve aerobic conditioning, we should involve a walking program to the patient. For phase 2, that will be a recovery phase that will go till 6 weeks. We should now in this, the patient should be able to understand, as I have told earlier, neutral spine concept. Patient should, you have to improve cardiovascular condition, trunk strength, soft tissue mobility, lower extremity strength and flexibility, and nerve root mobility. Now, the criteria to progress this stage is there should not be any sign of infection, pain. There should be gradual increase in the tolerance of the activity, demonstration of good knowledge about body mechanics, and performance of self-care with minimal modifications. Then we can take the patient into phase 2. And the intervention, you have to progress now the exercises that you have incorporated in phase 1. So you can add up now lumbar core recruitment in different positions. You can go for improvement in the sitting tolerance, soft tissue mobilization, cardiovascular training can go for 20 minutes. And you have to see that while performing hip extension, patients should not be performing lumbar spine extension as a trick movement. As we progress for phase 3, now this phase is basically for resistive training phase. In this, the anticipated impairments and limitations are like limited stability of trunk in challenging positions, limited tolerance to prolonged positions, and it is not necessary that patient will be independent in all self-care activities. So the goals are formulated to tackle these functional impairments, and the criteria to progress to this stage is there should not be any signs of pain, no loss in mobility and function, and good knowledge about neutral spine concept in different positions. So we can start with progressive resistive training. Dural mobility can be started with tensioners in third phase. From second phase, you can start with dural mobility with sliders. As I have told you that in the beginning, you can start with the contralateral limb as there is the nervous system is interconnected with each other. Then you can progress with the same limb, but remote sliders can be progressed to the proximal sliders and double-ended, single-ended. And then in third phase, you can go for dural mobility tensioners. So proximal, you can start with distal, then go for proximal, and then single-ended and double-ended tensioners. And lumbar core training with limb loading can be started now, because now the patient must have got the concept about how to maintain the neutral spine in different positions. So now you can add up limb loading in this, different levels of limb load. Trunk stabilization exercises can be given by challenging base of support. You can add up proprioceptive exercises now. We can progress cardiovascular exercises, and sport-specific drills can be introduced from this phase. Now about brace, there is a gray area in literature. It has been recommended that corset adoption does not improve short-term and mid-term outcomes of patient after single-level lumbar discectomy. So, as Dr. Ajay Kothari sir has also said, he will also not recommend brace to the patient, because patient dependency on brace increases, and it will further decrease the recruitment of the muscles. But for cervical spine, the literature says that for 3 weeks, it can be given after non-instrumental technique. Rest for other surgeries, it is not required. Now, what the recent literature talks about. With the increasing use of minimally invasive techniques and their proven effectiveness, pilot studies shown that implementation of rehab program in the earlier phase of surgery, post-surgery, it has a potential of effectively increasing the functional outcomes like pain, disability, and quality of life. And it is also associated with better return to work outcomes. And one more study talks about that is effectiveness of physical therapy and rehab programs started immediately after lumbar disc surgeries. They have incorporated home exercise programs, and that is a 3 months follow-up study. And they have found that incorporation of home exercise program has an additional benefit over the improvement in functional outcomes. So this individualized rehab program, what it talks about, they have given it for 2 to 3 weeks after surgery, twice a week for 4 weeks, and each session was for 30 minutes. They have taken primary outcomes were Roland Morris Disability Questionnaire and VAS, and they have found that there was improvement in 55% of patients with their post-operative residual leg pain, which is found in many of the patients as compared to the controls. So what this rehab talks about, rather than comparing a standard protocol, there is a multimodal approach, which should include cognitive behavioral therapy, how to tackle kinesophobia and apprehension of the patient. So we can incorporate pain coping strategies. Home exercise program, it also has a similar ground beneficial effect, so that the on follow-ups, we can find it out that maintenance of the exercises can be find out with home exercise program. And important is lumbar core stabilization exercises, so that patient can incorporate that neutral spine concept and recruitment of lumbar core muscles in different functional activities, so that there should not be any recurrence of the symptoms post-surgery. That's all. Thank you.
So thank you so much, ma'am. I think that was a very informative talk. Ma'am spoke about cervical as well as the lumbar spinal surgery separately, as well as she made it into a phase-wise rehab, which was good. And also what was good is she also included the precautions for assessment. She also talked about when to start with strengthening, especially for the hip flexors. Ma'am also talked about neural mobilization, when it can be started for the cervical spine, when it can be started for the lumbar spine, starting with sliders initially, or maybe the contralateral limb, which from where the symptoms were there preoperatively. So because the neural system is interconnected. She also added evidence talking about how return to work was better with early physiotherapy rehab, and these are recent evidences. So I guess anyone who's listening to this lecture has been very enlightened about how to go about with the post-operative rehab and the physiotherapy aspect of following spinal surgeries, whether be it cervical or lumbar. The added benefit of knowing the evidence about the use of orthosis or braces and the recent evidence showing that except for cervical spine, the evidence is very poor for the lumbar spine, added more information about how to go about with the entire thing, and also very importantly discussing it with the treating surgeon. I think that is very important because I guess they know what the spine was like when they operated on it. So recommendation whether the brace is required in the post operative period for a short period of time or not will also be recommended by the treating surgeon. So all in all, ma'am, I would really like to thank you for this very informative talk. I'm sure our listeners have been very benefited by this. It was a part of the series, which I think, again, as I would kind of tell you all that it was a part of the series of talk, which was kind of in collaboration of Physio TV with the Myers Physiotherapy College. And I'm very thankful to the principal of Myers Physiotherapy College, Dr. Snehal Gode, ma'am, and also the HOD of the Musculoskeletal Physiotherapy Department and our very own alumni, Dr. Ravinder, to have kind of brought about this collaboration of three talks where Dr. Kothari sir talked about the orthopedic aspect in part 1 and part 2, and Ravinder ma'am today talked about the physiotherapy aspect. I would kind of be looking forward to more collaborations with Myers Physiotherapy College for such talks in future. The Physio TV is a free for all, open for all YouTube channel for the physiotherapists by the physiotherapists. So I would strongly recommend other colleges to join the fray of collaborating with us and presenting more talks. Ravinder ma'am, I thank you so much for today's talk, and I wish we have more collaborations in the near future. So thank you so much, ma'am.
Thank you, ma'am. Thank you, ma'am, for giving me this opportunity. Thank you, ma'am.